Greetings. It's good to see all of you again today. Welcome to the 23rd of our Town Hall series. As always, I want to thank the members of our Society for Leading Medicine. I'd like to thank Jeremy and Caroline Finkelstein and Catherine and George Masterson for their chair of that this year and for all of their hard work. And thank you all for your support of Houston Methodist. You know, as we began last month, which we had tried to do in this fall a little bit as well, and then COVID had other ideas, we really pivoted from COVID and really focusing on many of the wonderful other areas and things that are happening at Houston Methodist and the exciting work that's being done and the incredible colleagues we have here doing such great work. And we're going to continue that today. I'll do a little update on COVID and a little update on some broader things at Houston Methodist towards the end. You know, as many of you knew and know, Dr. Tim Boone for many, many years, who was our chair of urology for many years, he chose to step down. He was also focusing as director of our Education Institute and really a liaison with Texas A&M around our NMed program and working actively with them as one of their deans. And we began a national search, and we were very thrilled to recruit Dr. Kathleen Kobashi, who comes to us from Virginia Mason Medical Center in Seattle. There she was head of urology and renal transplant as well as director of their pelvic floor center. So you're going to be hearing from her in a few moments. We're also going to hear from two other colleagues in the Department of Urology, Dr. Rose Kavari and Dr. Ricardo Gonzalez, and Dr. Kobashi will introduce them more fully a little bit later. During this process here, we actually, as we've often done with COVID, we now also have around all of your urological questions. We have somebody in the background working able to chat during the live stream here, and that's Dr. Keenan Celtic. So if you have questions, by all means direct them, and he will do his best to answer those along the way. We'll also accumulate them and answer them at the end. If you do have any questions that you want to send in, you can text them to Debakey at 37607. There'll be instructions on your screen as well. Dr. Ben Moreland is going to give us a quick introduction, or not Dr. Mr. Ben Moreland is going to give us a nice introduction in a second. Ben Moreland is on our board of directors. He's also on the board of directors of our Houston Methodist Academic Institute, and he's a member of our urology task force. So I'll turn things over to Ben.
Thanks, Mark. I'd like to add my welcome to Drs. Kobashi, Kavari, and Gonzalez for joining us today. As a patient of the department, I have been blessed to have received terrific care and results under the care of Dr. Brian Miles. In this experience, I learned firsthand how important it is that we continue to invest resources in the Department of Urology, and I'm pleased to see us once again nationally ranked in the specialty with upward momentum, which we will soon hear more about. The Urology Task Force, of which I'm pleased to be a member, advocates for the department with patients and in the community. Together with my wife, Wendy, we are pleased to support the department by contributing to funding of a program to develop online patient education through our very own YouTube channel to help us better equip patients to evaluate and participate with their doctors in making the best decisions possible for their care. Like most of you, I guess, on this call, I'm not a medical professional. So when I was presented with a difficult diagnosis, I immediately sought access to high quality information from trusted providers. I believe adding patient education resources such as these will improve the patient care experience, reduce the fear of the unknown, and is another way we can lead medicine. So thank you for the opportunity to participate today, and I'm pleased to turn the call over to Dr. Kobashi. Thank you.
Well, thank you very much. It's a real privilege to be here today to participate in this town hall, and I really appreciate the opportunity to be here to share with you urology today. I'm accompanied by my dear colleagues, Dr. Ricardo Gonzalez, who trained in medical school at Stanford University, followed by his residency and fellowship in BPH or prostate health at Weill Cornell Medical Center in New York, and Dr. Rose Kavari, who trained here at UTMB down in Galveston, followed by her residency at Baylor and her fellowship here at Methodist. So it's my privilege to go ahead and tell you a little bit about urology. I thought maybe I'd tell you a little bit about history that many of you may know. Houston Methodist Medical Center, or Houston Methodist Hospital, is about 100 years old, already just over 100 years old. But in the last 15 years, under the great leadership of Dr. Boom here, has been on an amazing trajectory. And we are now a greater than 2,200 bed hospital, covering 7 hospitals and with over 2,000 physicians working in the system. It is, more importantly, a multi-specialty tertiary referral medical center, which means that we really treat the most complex conditions and the most challenging conditions, and really can treat anything here at Houston Methodist Hospital. But who is urology? Urology is on a growth trajectory just like the rest of the medical system is, but we are now 18 surgeons, 15 residents, 3 fellows, and 2 advanced practitioners, and really on a mission to grow this out into our community and here at the medical center as well. I wanted to really talk about what urology is, because I don't think that everybody necessarily knows that. It is a surgical subspecialty that treats all conditions related to the genitourinary tract. So that's from the kidneys to the ureters, which are the tubes that connect the kidneys to the bladder, and the urethra, which empties the bladder to the outside, as well as men's health in regard to prostate health and sexual function, etc. And I'll delve into that just a little bit more as we speak. This field covers male and female and adults and children, though we don't have pediatric urology here at Houston Methodist, but it really spans a broad range of very quality of life related health issues. So our vision for our department here at Houston Methodist is first and foremost to serve our patients. We want to provide clinical excellence, we want to serve you well, and really take great compassionate care of our patients, and that is our number one mission. We do this by coordinating our care and our services across the organization. So we've got, again, 7 hospitals, and so we can reach the community that way. But in addition to that, we have sort of a traditional academic sort of a model where we also participate in innovative research, which Dr. Kavari will share with you just a little bit about that, what we're doing in urology today, and try to move the envelope and push the edge of things in advanced medicine and exceptional education of our future, to train our future, our peers, and our patients. With all of this together, we think of ourselves and hope to be a world-class urology department. So let me tell you a little bit about what we do as urology. Again, we're a top-notch team. We're really recruiting partners who are top-notch in their field insofar as leadership and expertise. We work in a multidisciplinary fashion with other colleagues across the medical center and across the nation and the world, actually, whose subspecialties cross with ours, such as colorectal surgery, gynecology, medical and radiation oncology, etc. So many different fields that touch ours. And what we strive for is clinical excellence, outcomes, service to our patients, and really being innovative as far as advancing the field. So what are some of the service lines that urology covers? This is what we have here at Houston Methodist, urologic oncology, which covers the whole gamut of any urologic oncology you may see, a stone center with specific expertise in stone disease, men's health center, which we'll talk about a little bit more, pelvic floor medicine and functional urology, which is something that we're going to focus on today as far as what we tell you, what we're telling you our services are. And then the Women's Urology Center, which is an important entity as well, because I think a lot of people don't realize that women see urologists also and should see urologists very appropriately. Another way to look at it is we've sort of divided ourselves into teams or divisions this way so that we can really provide you with the most advanced care in all of these fields. So let's talk a little bit about functional urology, and I'm going to speak a little bit about female urology and pelvic medicine. It's all really about perspective, isn't it? And I think a lot of you could probably relate to this. Is this a map of 20 Starbucks or 20 bathrooms? I came from Seattle, so that's why that's sort of symbolic for where I came from. But the point is that urinary incontinence or leaky bladder is very prevalent. It occurs in 25 to 45% of the population. As we age, the incidence or the prevalence gets higher, up to almost 60% of people in nursing homes. But what's also interesting to know is that women who are continent even at age 60 have about a 20% risk of becoming incontinent within the following year. So that was an interesting statistic, but suffice it to say that it's very prevalent. It is, however, very underreported and undertreated. In fact, less than 50% of women with significant symptoms actually seek treatment. And so that's very interesting. We've done there are multiple studies out there that really show that people, even when they have a significant problem and are sitting with a provider who could help them, don't even mention the urinary incontinence to them. And yet we can do so much to help. So that's what we're here to try to tell you about. The bladder has some responsibilities, if you will. There's two main responsibilities, and they are to store the urine and to empty completely on demand, but not before. So the bladder is not supposed to leak. It's supposed to only empty when you say it's appropriate. So when you look at the bladder here, this is a good figure to show you. The bladder is like a balloon, and it's supposed to hold urine, and then the outlet there, as you can see in the picture depicted, is not strong enough. So that's like a leaky valve in a faucet, or leaky washer in a faucet. And if that outlet isn't strong enough, if someone coughs or sneezes, they may leak. And for women, the most common reason why that happens is vaginal delivery of babies, though there are all kinds of other reasons why that can happen. The other type of urinary incontinence is overactive bladder, which is when the bladder squeezes when it's not supposed to, and the symptoms that people feel are frequency and urgency, like I gotta go right now and I'm not gonna make it in time. So these are the types of incontinence. I'm going to talk very briefly about the things that we can do specifically about overactive bladder and stress urinary incontinence, which, as you can see here, when you compare it to chronic conditions, is incredibly prevalent in the United States. It's also very expensive, as you can imagine. If we look at diagnostic evaluation and then absorbent products and how many hours of work are lost and productivity are lost, it's a tremendously expensive situation for the healthcare system. We partner with our patients. This is, it looks like a busy slide, but this is a tool that we use to sort of show our patients what the types of incontinence are that I've just talked about. But let's talk about some of the treatments. I also want to mention that this group, again, is really, trying to push the envelope and be part of not only new solutions in diagnostic procedures and treatment options, but really creating the guidelines, the national and international guidelines that we use to guide how we as urologists and urogynecologists treat patients with urinary incontinence. So really quickly, overactive bladder. The first line of therapy is really to avoid, bladder irritants such as caffeine or a glass of wine, which you can still have, but you just want to be careful not to, have a big cup of coffee when you're getting on the plane. There are medications that can be used, and basically the point of the medications are to relax the bladder or to keep it from contracting when it's not supposed to. But what if meds don't work? So those are the first and second line therapies basically, but there are guidelines-based therapies that we offer here, and we frankly do a great job at it. There's percutaneous tibial nerve stimulation, Botox injections, and what we call the bladder pacemaker. So just really quickly a quick overview of that. This is almost like acupuncture. So this is basically a small little needle that's placed into the ankle, and we stimulate that nerve, and you get 6 to 12 weekly treatments, and you just sit with us for about a half an hour, and the treatment is very simple. You could drive yourself here. Success rate is almost 80% compared to about 50% with medications, and sustained at 36 months for many patients. Botox injections is the same Botox that we can put in your face. We can actually inject it in your bladder and make you have a beautiful bladder that actually behaves. This has to be done approximately every 6 months, but it is an outpatient, easy procedure that you can do under local anesthetic and drive yourself about 1 to 2 times a year, and the success rate's about 80%. And then the pacemaker, which is really the most successful of the 3 options. It is placed under a little local anesthetic in the operating room, ultimately under sort of colonoscopy sedation, and you get this little battery that's about the size of an Oreo cookie. Success rate about 90%. So again, the reason why I tell you all of this is because I think it's important for you to have optimism and know that there are things that can be done and very successful, not very involved treatment options. And then lastly, stress incontinence very quickly. This is, again, the left side of this figure, which we always go over in detail with our patients when you come in to see us, and just gives you perspective of what you're dealing with. But again, remember, this is the weak valve. It's the valve that's not tight enough, So when you cough or sneeze, there's not enough resistance. So there's two main surgical options we can do beyond doing the Kegel exercises that everybody's taught to do after pregnancy. This is urethral bulking. So it's like, how folks are injecting collagen filler in their lips nowadays to plump things up. We can actually inject a material, a very benign inert material, into the urethra, again under local anesthetic. Success rate is quite good, actually in the 70% range, up to 7 years out of the European literature. But what it does is it tightens up that valve. And so you can go play tennis the next day. It's not anything that really is too much of a bump in your schedule. Lastly, this is just a picture of that, so you can see on the left side there, before the injection it's open, and as we inject it sort of bulks things up and really works quite nicely. And then lastly, there's the sling, and the sling is a little hammock beneath the urethra. Again, another outpatient procedure, but you get an anesthetic and it's done in the operating room. It's less than a 30-minute procedure. You go home right afterwards. You can't play tennis for 6 weeks or do any heavy lifting or rigorous activity. And there's been a lot of discussion about the materials we use for slings, which is a little beyond this brief talk for you, but we can use either this mesh material or we can use your own tissue. So with that, I actually want to go ahead and pass the baton over. Again, the success rate for that is about 80 to 85%, and it gives you your quality of life back. So I'm going to pass things over to Dr. Gonzalez. He can speak a little bit about the men's side of things.
Thank you. So first, thank you, Dr. Boom, for the invitation, Dr. Kobashi for the introduction, and it's honestly an honor to be a part of Houston Methodist, but part of this league of superheroes that we've developed in urology, where we all know the same information, but surgically everyone has a skill set. So I think of our department as Batman, Aquaman, Wonder Woman, Batgirl. Like we all, like depending on your problem, we have the person for the job, and the volume of the people and problems that we treat here is just world class and second to none. And I'm going to focus this talk, it's going to be like drinking from the fire hydrant, on the many, many things that have emerged that you're seeing on the news for treatment of benign prostate disease. BPH is the benign enlargement of the prostate. It's very common. There's a lot of advertisements for things like UroLift and Resume that are available, and patients often come in asking for that. And when I get asked as an expert, what is the best treatment? It's not about the best treatment, it's what's the right treatment for the right patient. So I'm going to focus this presentation on that to clarify the mess, that, just make it a little clearer, and just show you how we're kind of leading medicine here at Methodist. These are my relationships with industry, which has been primarily as a consultant and investigator on these new devices that you'll be hearing about. So we'll go over what is BPH. We're going to talk about why there's so many choices, how you pick the right one, both as a urologist and as a patient. And we're going to go through some case-based scenarios, real life, so you can see what like real decision-making looks like. And then we're going to divide this plethora of options, which are, I think, 12 FDA options, into either a MIST therapy, which is minimally invasive surgical therapy. It's defined as being able to be done in the office under local anesthesia, or surgery, which we're doing in the operating room and physically removing tissue. So BPH is benign, which means non-cancerous. Prostatic is the P, which is relating to the prostate, and hyperplasia, which is growth, more than normal. And the normal prostate is about the size of a walnut, but after puberty, the prostate grows until we die, and it grows at different rates. And there's two main things that cause growth of the prostate. Sorry, I'm just trying to find there it is. So this would be a normal prostate. The bladder wall is sort of thin. And when we look at a prostate that has grown, the bladder wall has thickened. And what that results in is a bladder that's less elastic. So the signs of the prostate growing are not only weak stream, but later, people who've had it a long time have frequency, urgency, and they get up at night. Prostate growth is regulated by genetics, but also by diet. People with hypercholesterolemia, high cholesterol, or diets that are rich in cholesterol are probably more likely to have this problem. I will mention the scale over and over called the IPSS questionnaire, and it gauges the different elements of how we urinate. So incomplete emptying, frequency, intermittent stream, urgency, weak stream, straining, nocturia, so how many times you get up at night, and then quality of life. And this will be scaled. The reason I'm going to mention this is a max score on this is 35. So anything more than about 20 is severe, and anything less than 8 is mild. So when we're looking at treatments, we have to know how many points it will reduce on this score. So this really, really helps us gauge how to target the treatment for the patient's goals. So why are there so many options? Medications are low risk, they have good benefit, but if someone's in urinary retention and you have a catheter, a pill might be too little too late. On the other extreme, we have open prostatectomy. Before, prostates that were bigger than 80 grams or bigger than a mandarin orange, we had to go through the belly, originally open, and it could also be robotically, open the bladder, get to the prostate, 30% risk of transfusion and 2 to 3% risk of death for an operation that is for a benign process. We've gotten better. TURP, the transurethral resection, is safer than that. Lasers are the same benefit as open surgery and TURP, but with 5-fold less bleeding risk. We have enucleation procedures that allow us to do bigger prostates in less time. And then we've innovated here with a truly automated robotic procedure called Aquablation, which sits in this surgical arm. The biggest space here that you see is between medications and surgery, and that's where missed therapies sit. And these are the therapies that you're seeing advertised a lot because they're quick, less than 5-minute procedures that we can do in the office. But clearly the benefit is not as great as we see with surgery. It's somewhere between medicines and surgeries. And there's 3 FDA approved ones, which are UroLift, Resume, and iTind. And I'm proud to say that Houston Methodist is the only hospital in the state of Texas that offers every single one of these therapies and has done the trials and have helped decide who benefits from which one the most. So this is a point of pride. There's nowhere else in the state you can have all of these options. So if someone's in urinary retention, which means they have a catheter, the prostate is enlarged, or they have kidney failure because the urine can't come out, they're having infections, bleeding is happening, or you have stones, that is a surgical problem. UroLift, Resume, office-based procedures are not for you. So we pick things from this list that I've mentioned, like vaporization, enucleation, TURP, robotic simple, Aquablation are therapies. However, if your prostate is smaller, so 30 to 80 grams, you're not in retention, you're sexually active, you want to preserve ejaculation, you want something done in the office and or local, then the missed therapies are Resume, the UroLift, which is prostatic urethral lift, and iTind. And we will talk about all of them, but I want to just give you an idea. So let's talk about Robert. Robert's a 68-year-old man. He's had urinary bother due to enlarged prostate. His IPSS score is severe. So we talked about that scale. More than 20 is severe, and he's 25. He had 1 episode of retention after his hernia surgery, had a catheter that was removed. He's taking a medicine, but really he doesn't want to take a medicine the rest of his life, and he wants to preserve sexual function. He doesn't want an operation or procedure that's going to affect that. So when we talk about efficacy, which is how effective the treatment is, here's a list. It's busy. We're going to circle the top 3. Those are the things we do in the office, and you can see that the IPSS reduction here is between 7 and 11 points. So Robert would go from severe symptoms down to moderate symptoms if we offer him something from that list. But if we offer him surgery, which is either our laser procedures or robotic procedures, he's going to have a much greater improvement in his symptom score of over 15 points. So if his goal is really urinate better, then we have to pick something from the bottom part of that list. Now, before, none of us have mentioned yet, but the prostate's job is to make the fluid that transports sperm. And so when we ejaculate, there's 2 parts of that. There's orgasm that comes from the brain, and then the fluid that comes out that transports the sperm. That is, a lot of that is made in the prostate. And the treatments, whether it's medicines or surgeries, used to always affect that. Part of our research here is to find ways to treat the blockage, but preserve not only erectile function, but ejaculatory function. And when we do office-based procedures, the risk to ejaculation is between 0 and 6%. That means that 94% or more of men who qualify for an office-based procedure can not only preserve erectile function, but ejaculatory function. And then now we have a surgery that we helped develop here called Aquablation that has over 84% of men, over 84% of men will preserve ejaculation, and we don't see any new erectile dysfunction after that. So before, the surgeries were more likely to affect that. Now with Aquablation, we can treat the blockage and preserve the sexual function. So you see the numbers there. And so what we're balancing here is whether we need a category of things that we can do in the office and kind of focus more on preserving sexual health, or whether we really need to get more tissue out of the way with something more durable and gives you a greater reduction in symptom score. So Robert comes back and he's like, Doc, I've heard of two water-based things. There's the steam procedure and Aquablation, which is Resume. They're very different. The steam procedure, Resume, is done in the office, and Aquablation is done in the OR. Let me show you two short videos showing you what this is about. So this is looking at Resume in the office. It's done under local anesthesia. We enter through the natural orifice of the urethra. We use a flexible needle to inject steam into the prostate tissue. Each injection lasts 9 seconds. It causes instant cell death in the compartment that we're treating, which is called the transition zone. And so we repeat this procedure every centimeter of length of the prostate. We avoid the sphincter, and basically we preserve the urethra during that. And over the next 1 to 3 months, the tissue is resorbed, taking pressure off of the urethra and alleviating symptoms. Obviously, injecting steam into the prostate makes it first swell. So people get worse before they get better. So if someone is teetering or their problem is quite severe, this might not be a good option because we by nature make you worse before we make you better. So now let me show you Aquablation, which would be a surgery we do in the OR. And it's a busy slide. This is an ultrasound image, and you see our robotic arm, which has a lens that goes through the prostate. That gray sort of tissue that has the moving line in it, that's the prostate. And we're positioning the robot and lens to be centered in it. And using image and computer guidance, we're telling the computer what we would like to remove. Much like a laser printer, you can tell it how to make something. But here we're not creating something, we're removing something. So using 8,000 PSI and a saline jet, we can use image guidance to remove the tissue that's planned. And what takes me a minute per gram with laser, so an 80-gram gland might be an 80-minute surgery, here I can do it in 8 to 10 minutes in an automated procedure using image guidance. Now the robot doesn't care if the patient bleeds or not, so after we're done with the robotic component, we have to step in, evacuate the clot, and stop the bleeding. But the whole procedure, independent of prostate size, is roughly about 45 minutes. So it's really a game changer, and again, you fix the blockage and preserves the sexual health. So sometimes I get asked, Doc, what are the chances that I'll be able to stay off of this tamsulosin or this medicine and avoid surgery down the road? Well, fortunately, the FDA has been more rigorous with the recommendations of how long we follow up patients. So we have 5-year data on all of the things we're offering now. And so if we were to do a Resume procedure, for example, I quote my men that there's an 85% chance that they have not had to restart medicines at 5 years, and a 95% chance that we haven't had to do surgery at 5 years. And with UroLift, it's similar, not as robust at 5 years, where there's a 75% chance. So there's 3 out of 4 men have avoided pills, but a little more than 1 out of 10 men needs a surgery. So retreatment rates are higher with UroLift at 5 points. And so these are so depending on what the goals are, again, it helps us pick what we're doing. If they ask me how long if I have Aquablation, what's my retreatment risk? And it's similar to laser. It's a retreatment risk of 1 to 1.4% per year. So at 5 years, 5 to 7% of men need retreatment, but 94 to 95% of men are fine. So this is very common. We're at a heart hospital founded by Dr. DeBakey, and we have a lot of patients on blood thinners. So, Doc, I forgot to mention that I had a heart stent placed, and now I'm on this medicine called Plavix. Does it change your recommendation? 100%. I will tell you that one of the things that I'm proud to have helped innovate is the development of laser surgery for prostates in men who are on blood thinners, because the prostate's a bloody gland to begin with. Now we have lasers that target blood. So since 2003, this has been something that I've helped develop. I'm going to forward this video a little bit, but I've taught this surgery in 19 countries out of the US. But basically what we do is we use a little fiber through the lens that aims light at the tissue, and the light is absorbed by the tissue, and we can vaporize it. We turn it from solid into gas. So it's literally being done by light. The target of the light is blood. So whenever there's blood in tissue, the laser works better. But basically we put the light on the tissue, and we can either enucleate or vaporize the tissue, but you can see it's relatively bloodless. So this is done without incisions. It takes about a minute per gram, so the bigger the prostate, the longer the operation. But generally people go home the same day. 9 out of 10 men go home the same day. They have a catheter one night, and retreatment risk is about 1% per year. That's enough of the videos. Either vaporization or enucleation with green light is feasible as an outpatient, including in men whose prostate is bigger than 80 grams, so we can do that without incisions. We can treat men on Coumadin, Plavix, all sorts of anticoagulants. So it's something that we're comfortable doing here, and men don't have to suffer with a catheter. Even if they're on a blood thinner, we have solutions. So let's clear the mud a little bit. We talked about all these options that we have available here. Let's divide it into two categories: missed and surgery. Who gets missed? Maybe medicines work, but you might not want to be on a medicine the rest of your life. If you're not in retention, you might be a candidate. If you're sexually active and would like to preserve maximal function, or even in men, like during COVID, when we couldn't do, we didn't want to use hospital resources, we were able to treat men in the office under local anesthesia with these techniques. Surgically, if you're on a medicine and it's not working, I wouldn't pick a mist. I would pick something from the surgical column. If you're in retention, kidneys are failing, you're having bleeding, we need to do something here. We would counsel you on your risks depending on the option that we're choosing, and we tend to favor laser in higher risk patients such as those on blood thinners. So take home messages, you have choices. The idea that we had to use a hot wire to scrape out the prostate, or people's fathers had prostate scraped with a hot wire and had a catheter for a long time, like those are old days, and that you have incontinence after prostate surgery or lose sexual function for benign prostate disease, that's 20 or 30 years ago. We've really come a long way. We think of these less invasive things for men who opt to maximize sexual function, and enucleation or laser procedures for men with big prostates or blood thinners. And really, one shoe does not fit every foot. So if you're only offered one treatment at the time of your consultation, open your ears, because sometimes there's so many choices that really we should be able to meet our patients' goals. But thank you for the opportunity to speak.
Thank you. May I also have the mouse?
Oh, yeah, sure.
Because there's some videos as well. I have this one. Thank you. Perfect. Good morning. Thank you for the invitation, Dr. Boom, Dr. Kobashi, Dr. Gonzalez. I also would like to thank Mr. and Mrs. Moreland for their generous support and the vision that they have to support our department, our educational endeavors. We look forward to working with them over the next few years to really put what we already have developed on the map and spread the word nationally, internationally. So thank you for your support. Here this morning, I just want to take a brief time to highlight to you what we have in the functional urology and restorative pelvic surgery division of our department. Dr. Kobashi touched on it. We do have a very strong neurourology division. We take care of patients who have had congenital genitourinary issues. There are many individuals who are born with spina bifida, sacral agenesis, cerebral palsy, and they undergo an amazing care when they're young in the children's hospitals. But when they become transition to adulthood, there's really not that many urologists or reconstructive surgeons who are willing or have the expertise to take care of them. And that's what we have developed here. We have a very strong transitional urology clinic, which I'll touch base on it. Voiding dysfunction, which Dr. Gonzalez discussed, and pelvic reconstructive surgeries, which I'll touch on as well. But we believe that we cannot truly lead patient care in functional urology without the pillars of research and education. So not only we're participating in clinical trials, pushing the envelope with patient care and really making a mark, but we are also doing it with research and education, which I'll give you some examples of. Yes. As I mentioned, we do have the first and the largest transitional urology clinic and neurourology clinic in the state of Texas. This was, again, my mentor's vision, Tim Boone, who brought it up to my attention in 2012 when I started here, and we put our resources together, and now we've become a center. This has put part of our division on the map. We've been invited to participate in guidelines, Spina Bifida Association guidelines for neurogenic bladder, and neurogenic bladder guidelines, so it really has helped developed the care for this group of individuals. Our office and our department, our division is equipped with state-of-art resources to take care of these individuals. As you may know, they need many times wheelchairs and Hoyer lifts and those sort of equipments, and we are very well equipped to care for these individuals. We have expanded our collaborations nationally. If you look at this map, this is a map of the United States with centers for neurogenic that participate in the neurogenic bladder research group. And if you take a look at it here, I do have to find there we go. There are only few centers in California, but then and then few centers scattered around the country. But in Texas, there's only one center. Here we are. In Houston, Texas. So we're very proud participant of this collaborative group that focuses on patient-reported outcome clinical trials and creates very innovative multi-center trials. What are our options for neurogenic bladder management? We, as Dr. Gonzalez mentioned, specifically for neurogenic bladder patients, every individual is very unique. We really have to get to know their etiology of their problem, what surgeries they've had, and what their goals are. So many times just modifying their behavioral aspects of their lifestyle, we can improve upon their symptoms. There are medications, there are older medications that we've used very commonly, but I'm glad to say that there are quite a few newer generation medications that have significantly less side effects than the ones that we used to use that cause significant dry mouth and teeth issues and those sort of things. Bladder Botox, it's been around for a little while. Dr. Kobashi mentioned it. We used to do it in the operating room. Now we do it commonly in the clinic. It takes less than 50 seconds to do it, and I'll show you an image. It's a video. It has really changed the way we practice neurogenic bladder. Neuromodulation that Dr. Kobashi mentioned we use for overactive bladder. We used to exclude neurogenic bladder patients because it was not MRI compatible. Over the last year now we have MRI compatible neuromodulation devices, and that therapy can now be expanded to patients with multiple sclerosis where we couldn't really use that option. And then finally, augmentation plasty. We used to do this open. This is how I got trained. We would make big incisions all the way in the abdomen and harvest a piece of bowel and then harvest another small piece of bowel to create channels for people to catheterize. Now we're transitioning to try to do this minimally invasive. We are one of the centers who's really trying to do this using robotic surgery, and I'll show you guys an image of that as well. But this is just the Botox that was discussed, the bladder being very tight, lots of wrinkles. We block the nerve that causes that spasticity with Botox and then makes it smooth and makes it wrinkle-free. So as you can see in this video, there are these wrinkles in the bladder, very tight, very spastic, and then we just, in the clinic, it takes less than a minute, and then we inject Botox and kind of span it around the bladder, making sure we get as much of the bladder as we can, so it relaxes and takes care of the spasticity of the bladder. So we'll make it smooth. Again, this is the augmentation cystoplasty. Again, in this image, you can see we used to create this in an open incision. We're creating a channel for patient to catheterize. And then on this side is a younger female patient who couldn't see to catheterize from below, but we were able to do this robotically with tiny little incision and create this small little channel for her, so she doesn't have to transition out of her wheelchair, and she can just sit there and literally use an empty Coke bottle and just catheterize and drain her bladder. So significant improvement in the quality of life with just trying to do these procedures minimally invasively. I do want to bring up a couple of slides about artificial urinary sphincter, because it goes way back at Houston Methodist and Houston itself. This was developed by Dr. Brantley Scott at Baylor College of Medicine and Houston Methodist and St. Luke's being the participating hospitals. And he has contributed a lot to the reconstructive field and neurourology field. But artificial urinary sphincter was originally developed and used in actually spina bifida patients. The very first patients who received it were women with spina bifida. And now we commonly use it in men after their prostate surgery where they have incontinence. And it has gone through a lot of changes, but there's a cuff we put around the urethra and a pump in the scrotum and a balloon in the bladder. So this is for women. We do this, it's commonly done open in Europe, and in men, obviously, we'll do this perineally. So this is also another aspect of Dr. Scott's contribution to our field. It's a penile implant, which now has the capacity of being flaccid or erect, that we do offer in our department with other physicians, Dr. Stark and Dr. Flores being experts in the field. But this is what I wanted to highlight. There's really not that many institutions around the country that does artificial urinary sphincter implantation in women anymore. Europe does it, France specifically has a good data, but we were the very first one who did it robotically in a woman. And as you can see in this image here, robotically we have dropped the bladder. You can see the female urethra P-tube, and we're measuring around the bladder and egg, and then we've found the right cuffed implant and then put the rest of the components in. So we've been able to lead that aspect of patient care within our field. So that's been pretty exciting. Dr. Kobashi mentioned on this, but we do take care of overactive bladder. There's a whole nother concept of underactive bladder, especially as we age. The bladder uses that tensile strength that it has sometimes, and patients can have underactive bladder. We take care of women with incontinence, prolapse, men who have incontinence either with slings or sphincters or other modalities. And in extreme situations, we may need to divert the urine. Again, we used to do these open with a longer hospital stay. Now we can do these minimally invasively using robotic surgeries where we have to remove the bladder for benign reasons that's not functional and then divert the urine. We also do a lot of minimally invasive fistula repairs. Unfortunately, sometimes fistulas can occur when there's an injury to the bladder. This is a gynecology following I don't know if I can see my slide here. Okay, so where the bladder was opened completely, and it was done in an open way, and now we do this very minimally invasive way, less destruction and better tissue coverage robotically. So we do a lot of fistula repairs in our department. But now I want to change focus a little bit and talk to you a little bit about the research endeavors that we have embarked on over the past decade. We do have a lot of clinical trials in functional urology, as many of them Dr. Gonzalez mentioned in the benign prostatic hyperplasia realm. We also do have trials ongoing right now in long-term outcome of artificial urinary sphincters, optimizing bladder Botox injection. We just concluded our basically stem cell, but muscle-derived for the patient stem cell injection for incontinence for women. And every once in a while, we take 19 stones out of a patient's bladder, and that just makes it the day for the patient and for us. So this is just one patient with 19 stones that we had to remove, neurogenic bladder again. So it really improves quality of life for our patients. A big aspect of our research within our department has been collaboration. Again, as urologists, if we want to lead our division, our department, we need to collaborate with scientists that are interested in our field, but can add to what we have. I was fortunate to partner with University of Houston engineers, biomedical engineer, and Dr. Zhang, and they helped us create machine learning. And these, on the top row, you can see a pelvic floor that we can model for individuals. This is a woman with kind of intact pelvic floor, so when there is pressure or Valsalva or coughing, there's some movement in the bladder, but not complete displacement. And then in the second video, I don't know if it's playing. Oh, this is the bottom one. So this is a sling that we were trying to figure out where would be the optimum placement of a sling, and we could create a computer model that shows that if you place it at the bladder neck, it's more obstructive, and if you put it in the mid-urethra here, in the second video, you see the bladder can descend without really getting obstructed. So a lot of modeling that can be used for education and also individualizing it to the patient. My personal lab focuses a lot on brain control over the bladder. Historically, we've used animal models because that's all we had to look at brain control over the bladder. But now we have state-of-the-art MRI equipment, especially here at Houston Methodist. We had the 3 Tesla, now we have 7 Tesla MRI, and we have taken advantage of this opportunity and have started to look at what are the regions in the brain that control our bladder. We don't think about it, but this other graph, this video on the right side that keeps going between blue and red, imagine somebody taking a scalp, part of your skull off, and kind of staring from top down. And this is what happens when your bladder is just sitting here filling, and then when you see that contraction on the top figure, which is the urodynamic, you can see how the activation pattern changes throughout the brain, so significantly involved. There are only 3 groups in the United States that are focused on this, the Pittsburgh group and the USC, and we're literally the only other one. We do have the largest multiple sclerosis individuals participating in our studies. So really leading medicine and research in the translational part of neurourology. We worked with Dr. Gonzalez, where he contributed to one of our studies where we looked at some BPH patients and overactive bladder patients. Now we're at the point that exploration is almost, it will continue, but now we have identified regions that we can think about modulating, stimulating non-invasively maybe to improve bladder control. And multiple sclerosis was the first group that we decided to look at, and we received funding from NIH and Houston Methodist Research Institute, where we identified 5 regions and used this non-invasive neuromodulation magnetic stimulation device to modulate these regions to improve bladder function. This study just concluded, and I'm excited to let you know that it was highlighted on the cover of 2 of our main journals. It did receive, this is one of the prestigious honors or awards in urology. It's international, and we were the grand prize winner for this. So it is getting a lot of attention in the literature and among our colleagues that maybe this is another way to treat bladder function or to address bladder function, to go beyond the bladder, to go maybe address the nerves to improve bladder function. So it's at infancy, but hopefully there's room to explore. And this is a study we did with Dr. Gonzalez, is that again, sometimes we do improve bladder outlet obstruction with prostate surgeries, but some of the symptoms still stay, and maybe the problem is not just the prostate or the bladder, maybe it's the nerves. So we're able to use our functional MRI platform to look at the brain in these individuals. We also explored the effect of medications we use for the bladder on the brain, because now there's a lot of data on that. As Dr. Kobashi mentioned, we are leading our department with expanding in the educational realm. I also am the residency program director for our department, and which we started in 2016 under the leadership of Dr. Boone and Dr. Miles. And we used to take 2 residents per year, and now we're 3 residents per year. So it's pretty exciting times. I do want to conclude with this slides, and I want to thank all my mentors, collaborators, Houston Methodist Hospital Research Institute, who basically helped me with the very first clinician scientist grant scholar program and supported my efforts financially and helped us develop this pretty productive, I think, few years of work. This is from 2015, end of 2015, which I received the first clinician scientist award, until now that we've had over 45 publications. We've been on 3 different guidelines, almost 17 active trials. I have had many involvement with the NMed students. I have 4 of them in my lab. So the resources and the support have been tremendous, and I'm truly grateful for it, and I look forward to the future. So thank you.
Well, thank you, Dr. Kavari. Fascinating. Thank you to all of you. You know, as many of you know, I still practice a little bit of primary care, and it's one of the more common things we clearly see in both men and women, and often suffered in silence and not brought up. And so please do bring things up with your primary care physicians or others so we can get you to the right people. You know, I always, as a primary care physician, learn a ton from all of you and here, and makes me a better primary care physician, but I also, as an executive, learn some things I can shamelessly steal, like League of Superheroes. I love that. So that may get stolen, although you know, one of the great things about Houston Methodist is we have leagues of superheroes across all these specialties, and each month you're going to get to see that. And it's probably been a long time since, and probably too long since we've talked to you about urology. Although I must say, I'm going to make a bad joke here. You've got to be Aquaman, right? I mean,
or Green Lantern.
Or Green Lantern. Aquaman, I think.
Or Superman, laser out of the eyes, or something.
Yeah, that's cool. But you do plumbing, so you know it's Aquaman.
Yeah. Sure.
But seriously, I want to. We have lots of questions coming in. Y'all have been very active in the chat, which is great. Thank you to Dr. Celtic, who's been answering a lot of those, and we're going to bring some of those in that are kind of broadly representative and interesting to the group. But we also have a bunch that came in beforehand. I'm going to start with Dr. Kobashi. Actually, the first thing I want to hear, Dr. Kobashi's been with us 4 months. I'm giving her too much time. So you chose to come to Houston Methodist after we did a very extensive national search, and of course we were thrilled. Tell me a little bit why you chose to come to Houston Methodist.
Well, thank you so much, Dr. Boom. I mean, again, as you can see, the innovation that's going on here at Houston Methodist is tremendous. Under our executive leadership, I mean, the trajectory is amazing, and the dedication and the vision of our leadership to really be world-class in all fields is evident by, you know, the trajectory that we're on. I mean, I'm seeing this in all the leagues of superheroes within our organization now, and I'm proud to be a part of it. It's a huge privilege. But it's that dedication. It's first and foremost the dedication to clinical excellence and to really providing compassionate, state-of-the-art care for our patients, number one. But also to being part of the new thinking, right? Really advancing the field, taking it the next step, asking those questions about how we can do better, and really having those resources and the support and the dedication from our leadership to support that vision, and from generous donors in our community who have been so involved, like the Morelands. Thank you very much. I would want to add my thanks to the Morelands. But I think that was a beacon for me to move across the country, which was no little decision. But I am so happy. It's 100%, 1,000% the right decision. Thank you.
Well, great. And you know, one of the things back to that League of Superheroes is, you know, urology doesn't travel in a vacuum. You know, this type of cancer doesn't travel in a vacuum. Heart disease doesn't travel in a vacuum. You've talked about MS and neurological disorders. So that ability to have superheroes kind of across all the different specialties 100%. Has got to be huge when you're caring for patients.
You know, and I see that across this organization. Everybody is very enthusiastic about that cross collaboration and the ability to share across the fields, because that's, you know, we're all better together than we are by ourselves in silos. So it's an amazing culture here.
Fantastic. Well, I want to ask you a question that came in, and that's very broad, but it kind of, and it really applies to all of y'all. As we heard about, you know, we've heard about treatment of BPH, we've heard about treatment of, you know, functional issues, incontinence. Obviously, we didn't talk as much about cancer today, but it would apply to many of the cancers. There's so many choices, you know, and so many possible therapies. They all have their pros and cons. So we talk about shared decision making in healthcare. Yes. I mean, nowhere is this more important than in the kind of things we talked about here. So talk 100%. About how we've structured ourselves and how you focus on shared decision making with the patients you're serving.
Absolutely, 100%. I mean, that's been a big advance in medicine overall, I think, is that we really, our job is to really provide the information and to make things understandable. And we speak to each other in medical lingo all the time, but we need to make it so that we can have a conversation that everybody at the table understands, specifically typically our patients. And so we sit and we really invest a lot of time. So that tool that I just showed you very quickly that we use to talk to our patients about incontinence, for instance, we have those across the board. Whether we're talking about prostate cancer or we're talking about erectile dysfunction, that sort of thing, we do have tools that we have developed and continue to update and develop in order to make sure that we're making things understandable for our patients. And together we look at all the options, the pros and cons of each of them, like Dr. Gonzalez did present, like why certain treatment options would be better for one individual than the other, and we really do our best to try to make sure that everybody is on board with that so we can make decisions together. There was a question about how we record our discussion about that, or how we make sure that we've really covered all of that, and that is in, every physician after our visits, we record a note, we dictate a note, and we try to keep record of how we've had that discussion so that if it comes up again, we can reiterate the things that haven't been very clear. But that is absolutely the focus of medicine. Wouldn't you say, Dr. Gonzalez?
Yes. Yeah,
So, so I'll pick up on that, because you actually showed us a situation where I think you had 12 options, as I recall.
Yeah.
That's a lot. That's really overwhelming if you're a patient.
Yes.
I imagine for given patient A, 12 options don't make sense, right?
No.
So you're going to already have hone that down to things that make sense in this case. We're talking BPH, so in his case. But then how do you spend the time with them? How do you arm them with the information to with you make the best decision so there's no regrets?
That's a great question. So you have to combine what you hear from the patient in terms of patient goals, what bothers them. Not everything that they're experiencing is a bother and needs to be treated. Combined with the objective data that we know, like how aggressive is the cancer? Is it localized? If it's not cancer, if it's prostate enlargement, how big is the prostate? What's the shape of the prostate? So sometimes just the goals and what you hear out of a patient's mouth might not be what, you have to look at the objective data. What was the symptom score? Is the patient using a catheter? Are they in kidney failure? And then I narrow it into like a less invasive option, a more invasive option, an observation option, and what the risks are. But it's our job to help the patient navigate this pathway, and it's our job also as leaders to help find what the likely outcome is of each of these pathways, because all of us serve on guideline committees to help decision making by other urologists at other centers, because the easiest thing to do in the community sometimes is I'll hear a patient say, well, I went to ask my doctor for whether I was a candidate for UroLift, and he said yes, but he didn't take measurements or did anything. I just wanted a second opinion. I'm like, well, how big is your prostate? How, what's your PSA? Have you, I need this information. And sometimes that's not, it's important to have everything in front of you when you're guiding the patient. So fortunately at Methodist, we have the diagnostics, we have the team-based support. Our network's very integrated, so if someone comes from the community, we have access to their records using Epic and Care Everywhere. We can see at other institutions what has been done and what's lacking, and putting all of that together, we help guide the patient towards the right therapy.
So I heard you say something pretty important before. I just want to reiterate. I think you said, when you're talking about some of these areas where there's so many choices, obviously there's parts of medicine where there's not a ton of choices. It can be a little more cut and dry. If somebody's telling you this is it, this is what we're doing, that's a red flag, right?
Yes.
You really should be in a situation where you're at least talking about the fact that there's an array of options, even if quickly you end up focusing on one or two.
That's right.
Okay, so
that's
some great words of advice to everybody. So, well, good. Well, Dr. Kobashi, I'm going to ask you a question that we got. So we've talked about bladder leakage and a bunch of other things. We had a question about bladder retention and basically incomplete emptying. So people who are not able to completely empty their bladder. Can you talk about that, what that means, and potential treatments for that, and obviously potential problems that can cause?
Absolutely. So let's talk about non-neurogenic urinary retention. So the last 30 years, our field has focused on overactive bladder until recently that we've kind of developed this terminology. Then now we have a diagnosis, we have a name, and we can work with it and try to do research and investigate. And that's voiding dysfunction or underactive bladder. It can have still different etiologies, but most of the times it's because the bladder just loses its strength to get the urine out. So it's an underactive bladder. Sometimes there's a dyssynergia between the sphincter that doesn't relax, but most of the time it's just the bladder that loses its strength. And many times it happens with aging. We really don't have, unfortunately at this point, any pills or medicines or anything that we can give the bladder to make it just a little bit stronger to get the urine out. We can work on the outlet and on the sphincter to make it more coordinated with the bladder, so when patient strains a little bit, then hopefully they can empty their bladder better. There are medications we can relax the sphincter a little bit. There is neuromodulation, the pacemaker we talked about, that can also coordinate the activity of the bladder and the sphincter to help the bladder empty. But I think that the future probably is neuromodulation, whether being in the spinal cord with what we currently have, or moving up to the brain and using non-invasive brain modulation to empty the bladder. One of the thought processes is that maybe as we get older, the brain just doesn't see the sensations properly from the bladder. It just doesn't process it better. So if we can promote that sensation, maybe we can trigger the switch and we can help them better.
Great. Thank you, Dr. Kavari. So let's kind of follow on a little bit in that same thread here, which is incontinence. And of course, we see incontinence in men and women. We see a lot of incontinence in women. I mean, I kind of talked about don't suffer in silence. I mean, I think back to when I started out, honestly, we all thought of urology as a male field. It was all about the prostate, right? And the reality is, obviously, both men and women, for different reasons, have many issues. And obviously, women, especially if they've had children, have significant problems with incontinence. Talk about that, and talk about the kinds of things that we can do, and maybe the triggers for who should actually see a urologist versus are there levels where maybe you don't need to.
Right. Well, I mean, in simple terms, it really comes down to bother. So the degree of bother that it causes you is the trigger. So if it bothers you, for instance, and some people might be bothered by only leaking when they serve a tennis ball, and we can treat that. Some people may have a lot more leakage and not be bothered. We don't have to treat that. So Dr. Gonzalez alluded to that. It really comes down to how much a symptom bothers a patient. And in fact, that's part of the guidelines that we were part of, that really the degree of bother has to be part of the equation. The bottom line is that any sort of bladder overactivity, when you gotta go, and you can't get there in time, it starts to come out before I can get there. We have a nickname for that. That's called the garage door syndrome, and anybody who experiences it knows what it is. You can drive home that last 10 miles and have to go, but you can make it, and then as soon as you put the key in the door or push the garage door opener, your bladder just feels like it's ready to go. So that can be a huge quality of life issue, no question. We can absolutely treat that. We went through some of the treatment options very quickly, but those options are there, and what we don't want is for people not to ask what's available. We've got, it's not just medications like it used to be. Now we've got a lot of things in our armamentarium that are very successful and not really a big deal. They're outpatient procedures. On the flip side, the coughing, laughing, sneezing, serving the tennis ball leakage, that can get in the way too. A lot of people will come in and say, I can't run anymore, I can't exercise anymore because I leak. Well, we can fix that, so you can exercise again, and it's sort of a vicious cycle. If you can't exercise because you leak, then you don't exercise, then, the bottom line is that if it's interfering with your quality of life, there are a lot of things that can be done. And that goes for male and female. And there are some really simple things that we can do, as we alluded to also, that are just behavioral changes, like changing how much caffeine you drink, or if you have a glass of wine, just be strategic about it. You don't have to cut everything out. You just want to be strategic about those triggers that might make life a little tougher for you. So, the bottom line is when or who should come in. You can come in and see us if any of these things are questions for you, and we're happy to, try to either reassure you that it's not anything that we need to do anything about, or, chat about it and talk to you about all these options in a little bit more detail than what we talked about today.
So you talked about being strategic. Yes. One of the questions that came in over the chat here was around, I drink a lot of water, and it seems like I'm always going to the bathroom. So talk about strategies, because really those apply to almost everybody who's having an issue. They're the first thing you would do. Talk in a little more depth about if you were sitting down with me or my wife or whomever as a patient, and you're going to say, what is the right amount of hydration and timing of hydration? What about alcohol? When would you use it? What about caffeine? What would be those first things?
That's actually a great question. I have a slide that I use with this is, somebody urinating into the ocean and drinking something at the same time, and basically what goes in comes out, right? I mean, so that's basically what it is. So, I think the first thing is that more is not necessarily better. Some people come in and say, I drink 3 liters a day. Well, of course, you're going to go more frequently because what goes in has to come out. Usually, the 60 ounces or so, 60 to 70 ounces of fluid is good. But if you're having bladder control issues, we usually will say 40 to 50 ounces. And that's plenty, unless there's a reason that you need to drink more per your primary care
So that's
treatment.
1.5 liters-ish.
Yes,
Something like that.
something like
if
that.
You're thinking that way. A day.
A day.
is what you're
A day,
saying.
that's
Okay.
fine. Now, the choice of the type of fluid that you put into your body also affects your bladder. And so, again, as I alluded to, you don't have to eliminate your cup of coffee or your latte or your glass of wine. You just want to be strategic. So if you're getting on the plane and you've got the window seat, you don't want to come on with a big old cup of coffee. Or if you're going to the movies, you might want to wait for your glass of wine until after the movie, or sit on the aisle so you can get up. I mean, so that's the strategic part of things. If you can give all of that up, then that's great if it helps. Now, the other thing is not everybody's overactive bladder is because of the fluid intake or fluid choices. So, and there are other things like caffeinated beverages and citrusy things and all kinds of things, but those are the most common culprits, especially where I came from in Seattle, where there was the caffeine in the wine. But yeah.
That's very, very helpful, and really applies to probably everybody listening here. As everybody gets older, they learn never pass up a bathroom, right? So, Dr. Gonzalez, I want to ask you a couple questions about prostate cancer, because we didn't really talk about that too much today, but obviously a huge part of this field, and quite a few coming in over the chat as well as prior. So I have one here about somebody who had prostate cancer robotically removed, so robotic surgery back in 2006, and asking about an artificial sphincter. We know obviously leakage is one of the potential side effects, sequelae of that surgery. Talk about artificial sphincters.
So perfect. So as Dr. Kavari mentioned earlier, the artificial sphincter was invented in this medical center, and it's probably the standard of care. It's our gold standard for severe incontinence post-prostatectomy, but the leakage is always not in everybody does it warrant a sphincter. A sphincter is a mechanical device, as you saw on a slide earlier, that has moving parts and has valves and reservoirs, and it's a surgical procedure. But if the leakage is mild, maybe just activity-based, as Dr. Kobashi mentioned, during tennis, but most days there's not a lot of leakage, then maybe something like a sling that doesn't have a moving element is a better option. So we have different forms of male slings that we can use. For people who have post-prostatectomy incontinence, it is slightly less. And if you wanted to do a home test, if you're using pads, you can do a 24-hour pad weight. So like an incontinence pad doesn't weigh very much. You don't have to get it before weight, but using a kitchen scale, if you're leaking more than 500 grams of urine a day, then a sphincter by far is the best option. Or if you had your prostate removed and also had radiation, then the standard of care would be a sphincter. If the leakage is less than 500 grams a day, let's say it's 250 grams a day or less, and you have not had radiation in addition to the surgery, then a sling might be a better option for you. So there's certain guidelines we've made in our decision-making process to help a patient navigate that path. Also, a sphincter requires you to be able to pump the activation device in the scrotum. So you have to have the dexterity and ability to feel and activate that. So some of our patients might have a big belly or might not be able to see the scrotum or might not be able to reach, and that might not be a good candidate for a sphincter. You need someone who has good dexterity and will be able to activate the sphincter when they want to urinate. So it's very effective, but just like everything else, all the other technology we've spoken about today, we need to fit the right treatment to the right patient for that problem.
Great. So, and one follow-on question, somewhat related, but also in the field of prostate cancer, came in over the chat, and that's somebody who has had radiation and then Lupron, so that's kind of eliminating effectively their testosterone. And they asked the question of number of years out after their cancer, is there ever a safe time to have testosterone therapy for that individual?
That is a very hot topic right now, and fortunately, the pendulum has normalized when most experts agree that after being disease-free for 5 years, doing replacement of testosterone is safe if you're replacing someone into the normal physiologic level, not superhuman levels. But the needle has even moved sooner, and there's some evidence showing that men who have their prostate removed, so not for cancer that is just contained to the prostate, and thought to be cured by removing the prostate. So you take out the prostate, the PSA becomes undetectable. That if you start testosterone replacement then, that you don't increase risk of recurrence, and you might have better outcomes in sexual health, better recovery of erections, better muscle tone, which might translate to better urinary control. So in well-contained cancers that you can, that like margins are, you take out the prostate, they examine, the pathologist will look under the microscope and confirm that there's nothing outside of the prostate. In those cases, the decision to replace testosterone sooner is an option. Now, just as an aside, when we're going through stressful things like cancer, when your body's making stress hormones, sometimes you make less sex hormones because your body is busy with survival and coping. And so you might not be making testosterone, not because your testicles failed, but because the pituitary is not sending the signal to the testicles. So like in our men's health clinic, we evaluate pituitary levels because sometimes we can make the body boost its testosterone naturally without having to go on testosterone replacement. So it's a complex field, like everything else we've spoken about, but with the right team, we help our patients make the right decision on the correct treatment.
Well, I think I'm tempted to ask you more testosterone questions, but we probably could be here all day because I know that's such a hot topic today, and I'm going to need to wrap things up in a couple of minutes. I wanted to ask Dr. Kobashi another question about neurogenic bladder that came in. Somebody who self-caths in order to void previously had an InterStim in 2013, but it's not working. Is that something they should think about doing again? Are there newer therapies since that time? And explain just a little more what a neurogenic bladder is. You touched on some of that in your talk, but just to remind everybody.
So I wished we had the problem that Dr. Gonzalez has, that he has 12 options to choose from. Right. Unfortunately, for neurogenic bladder patients that have trouble completely emptying their bladder, we really have limited options. And that's what most of my grants have been focused on, because we have so many options for overactive bladder, but for bladder emptying in this day and age, we honestly just give patients catheters at the end of the day, and that's the most effective way that patients can drain their bladder. So options are very, very limited. InterStim or sacral neuromodulation is something that we can consider, we have considered. Now, the device has changed, the lead has actually changed over the past few years and has become more optimized. It has a little curve into it, and the device is more MRI compatible. So there are ways to assist the older generations of the sacral neuromodulators with x-rays, just to make sure it hasn't migrated, been pulled out, changed, or maybe the battery is just not working anymore. And then if there is a need or there's a desire to check with the newer generations, we've learned, we've even become better at placement of these devices, so we can do another trial. The neuromodulation, unfortunately, it doesn't work for everybody, but it works for a limited group of people. So we don't implant everyone, we do a test run, and that's, again, one of the beauties of it is that we can implant a temporary lead in the clinic, maybe on the other side, and have the patient tested with a diary, catheterize, and keep records. And if the bladder emptying is improved, meaning that they need less catheters or their flow is better, then we can go ahead and do the implantation or do it in a staged fashion. So there are ways to optimize the older placement of the neurostimulators, but the newer device, or even give it another try and test the other side.
Fantastic. Well, thank you. Well, I want to thank the 3 members of our League of Superheroes here today for some wonderful, wonderful presentations. Fascinating. I learned a ton. I hope each of you learned a ton as well, got many of your questions answered. We still have ability to answer questions on the text, so keep them on the stream, so keep them coming in. But I'm going to now shift to about 10 minutes or so presentation of closing and 1 or 2 questions that come in around either institutional or COVID issues. So let me give you, thankfully, a quick COVID update. I'm tired of giving COVID updates, frankly, but it is important to, and of course, a common question I get asked. This is the famous curve I show you every month, and it's about as good as it's been. So we're very happy to see that. We are actually under 100 patients in-house with COVID across the system for the first time since June of last year, and really close to our record low number since it started going up at, in March of 2020, once it was past that point. So we're crossing our fingers that things look pretty good right now. Testing is consistent with that. This is our testing volume. Obviously, you see Omicron and how severe it was in terms of the number of people who were tested positive. Thankfully, no more severe. I mean, actually, on a proportionate basis, less severe than previous surges in the hospital, but so many people sick, we had the same peak level of hospitalizations. It came down very quickly here, continues to do so, thankfully. And this is what we see in the wastewater around Houston. So if you remember, I've shown you this before. Houston, the way the city did this is they pegged July 6th of 2020 just as a reference point, and then everything's expressed as a percentage of how much we see since that time. You can see that they adjust this every week. It drives me a little crazy, but in the current version here, when you look at the peak of the Omicron wave, it was at 1,000%. So it was 10 times as much in the water as there was back in July of 2020. Two reasons for that: each person shedding more, so Omicron you were shedding large amounts, but also way more people having Omicron. We're down at 18% now, which is really superb, and you can see, consistently low, probably leveling off, so it's not going away. I wish it was. Now, the big question, many people are asking me is, well, what about BA2, or what's called the stealth Omicron variant? It's called stealth because of just one of the intricacies of how it's tested, and there's one of the pieces you look at on some of the tests that doesn't show up. It's not stealth as in all the testing doesn't catch it. It's just a feature of one kind of test that's out there. We catch it with every other test we do. What we're seeing around the world is a couple of things. In the UK and Europe, we've seen their nice decrease that they led the way on is now going back up at a slower rate than what it did, and not resulting in dramatic levels of increased hospitalizations, although some increases. Of course, concordant with that in Europe, they basically released all their restrictions this winter. They had been way tighter, not the UK as much, but certainly Europe, and way tighter than the United States up until that point. And then when they stopped. And so it's hard to tease out how much is BA2, how much of it is that. It does appear to be about 50% more infectious than BA1, which is Omicron. But it's not at a point even where the World Health Organization has named it as a different Greek letter at this point in time. In the US, what we're seeing is US-wide, it has come up. There are a couple regions like New York, I think in Massachusetts right now, where it's hit more than 50%. And with that, they're starting to see an increase. So there seems to be, when it's kind of hitting 30, 40, 50% of samples, you do see some increase. But it does not appear that it's causing these big spikes. It appears it's causing a little more gradual increase. Here at Houston Methodist, as we've talked about before, we sequence every single viral genome that comes through. I think we're 92,000, 93,000 and counting. Put that in perspective, there's been maybe 3 or 4 million around the world that have been sequenced. So, I mean, it's a prodigious and amazing effort here. We went from 2 to 3% up to 5%, came back down to about 2 to 3%. Now we're back up at 5% of our samples are BA2. So, knock wood, we've not seen it take off. But I do think, if I was guessing, educated guess, we're going to see some uptick over the next couple months. It's interesting to see what happens with warm weather, which means more indoor living in Houston, which we've seen the last 2 years. So likely we'll see some sort of surge. I don't think we're going to likely see a huge spike nor a huge spike in hospitalizations. The other thing, of course, is in Greater Houston, we had such a big Omicron surge. Omicron infection, vaccination both protect against the stealth variant or the BA2. And so I think we do have a lot of immunity out there, and so cautiously optimistic. And in fact, if you look at some of the national predictions, none of them right now look too alarming. So kind of my message is the same it's been: seize the moment safely. In fact, it's even a better seize the moment safely moment right now than it was a month ago, but be ready to pivot. And so, I do think it's important that we do appropriately loosen some restrictions, so that when it's time to tighten them again, it's not just more of the same thing. It is, things have changed. And we do a really lousy job at both parts of that statement. And I think that's our job is, this next time around, when it is time, if we see another Omicron coming, if we see BA2 starting to cause a problem, that we pivot. Just a couple data points here. Now the dust has really settled in the normal ways we measure things. This is now 2020 data, but these are now the kind of final numbers in effect. 350,000 Americans died from COVID in 2020, third leading cause of death, and far ahead of numbers 4 and 5. And then you see the age distribution there. What we've always talked about is that particularly as you get very elderly, but even as you get into your 50s and 60s, the mortality really begins. And sadly, with enough people sick, we still unfortunately see the younger individuals. A couple just interesting things out there. I'm not going to go into them in great detail, but this is France. Yet again, we look at this. Boosters work. The bottom line is, whether you're talking infections, it's not perfect. Boosters are way better than if you're 2-dosed, and way, way better than if you're 0-dosed. And if you look at then the severe things down in the bottom, you see hospitalizations and you see people requiring intensive care. Essentially very, very small numbers in the people who've been fully boosted requiring that. So another study here in the US looking retrospectively now, both at a Delta time period and an Omicron time period. I won't go into great detail, but when you get the slides, you can follow this in more detail if you'd like. But the bottom line is highly effective. And even if you look at 3 doses versus 2 doses, you're getting significant level of benefit. So you need to get boosted. And so we are still offering that. I would encourage you to do that. So easy to get. You can walk in anywhere. If you have not yet gotten your booster, get your booster. Now, the next question I'll get asked a lot then is, well, what about another booster? The data is still all over the map. I mean, nothing bad, but unclear whether you really need to do that or not. Clearly safe. We're not seeing anything that would cause that to be considered unsafe. That, if you have high risk, if you're elderly, if you have multiple health problems, a discussion you really should have with your physician, because technically to get a 4th dose, which you can in either Moderna or Pfizer, is a prescription issue. So your doctor can prescribe that. I will say, with people like my parents, with one of them entering some therapy on some things, I went ahead and got them another booster, about 6 months out. As I talk to my patients, the people who are higher risk, we're looking at that. But right now you're sort of juggling 2 things, because a lot of people are going to be 6-7 months out right now, which is about the time we think a booster makes sense. But COVID's really low. And so, what I'd love to have, in the perfect world, is you've got lots of sort of acute phase antibodies, so the antibodies that come up right after you give a shot in place when there's a surge. So if you're not super high risk, what I'm telling most people is, kind of watch things. And if it looks like things are about to go up and you're 6-7 months out, you might consider a booster. And again, talk about that with your individual physician. Just a few other things to talk about. This one actually is COVID related, but it's just an amazing story going back to leagues of superheroes that are here at Houston Methodist. This is about a young man whose lungs were ravaged by COVID and his life being saved by a lung transplant by our transplant team. We are among the handful of hospitals in the country have done the most lung transplants for COVID. And it's really a lovely, beautiful story, a 3 or 4 part series in the Houston Chronicle. Many of you may have seen front page. If the links are there if you'd like to see more detail. Carrying on in the transplant area, just last week or last 2 weeks, they had a 2-part series through NPR. It was Scott Simon from NPR Weekend Edition who embedded here at the hospital. And so it's obviously an auditory, story, and 2 nice, long, beautiful stories about this kidney swap. But if you go to their website, these are all pictures pulled off of the website of our transplant team that coordinated a 10-way swap. What this is, let's say my loved one needs a kidney transplant. I want to give them a kidney, but it's a bad match. They literally then use a complex algorithm and database to find, and sometimes it can go even higher than 10, but they found essentially 10 donors, 10 recipients, and it's like a chain. So I give my kidney to somebody I've never met, because they're giving, their loved ones giving their kidney to someone else they never met, and so on, kind of creating a chain in a circle where everybody gets transplanted. It's really a beautiful story, so I'd commend you to that as well. About 2 weeks ago, we got to do a really great presentation at something called VIVE. This is now, it's a combination of a couple entities, but sort of the big digital health conference nationally, and this was in Miami. We actually were the keynote presentation there, talking about our future, talking about essentially the smart hospital or the hospital of the future. So if you recall, we announced a new hospital in Cypress on 290. Actually, the fencing's going up, literally actually just started going up, so construction and all the preparations happening as we speak. And this whole focus is on how do we have a digital hospital of the future? How do we use that as a learning bed, working with many partners, and then really move that out to all of our other facilities and serve as an example. It was about a 25-minute deal. You can find it through this as well. Kind of a very TED Talkish kind of feel that three of us gave there, and very, very well received. A great chance to sort of show off the great innovation that's happening at Houston Methodist. I always talk about, focus on the fundamentals, and the accolades or the awards will follow. A whole bunch of those coming in recently. Health Grades, which actually is kind of a for-profit hospital ranking deal. We usually, pretty much always, show up in their top 50 hospital list. It's all data-driven, not reputation-driven. Well, they actually went and they said, where are the hospitals that kind of did the most and did the best during COVID for COVID patients? Now, they come out and say, first off, obviously some parts of the country didn't see nearly as much COVID, so they don't show up on the top of the list. So you're talking about the Northeast, you're talking about the South, you're talking about the West Coast, not as much in the Midwest. They didn't rank them, they just said, here they are. And Houston Methodist Hospital, in terms of volume and in terms of outcomes, our main hospital here was one of those 24 they recognized. So a nice shout out to our people who've been, putting their lives on hold for 2 years, taking care of COVID patients. A couple other interesting things. Newsweek, for a few years now, like other magazines, which figured out nobody buys magazines anymore, and so they get into the ranking business. They got into the ranking business, and instead of, obviously U.S. News has the U.S. rankings, so they said, well, we'll do world rankings. And so we don't chase these things. We focus on the fundamentals. But it was very happy to see we were on their list of the world's best hospitals, and proud of our team for that. Similarly, Forbes actually looks at best employers, and they looked at the large category of employers. They ranked 500 large employers, all with externally focused data. We don't apply, we don't send them data, it just shows up one day. We were ranked number 37 of large employers in the country, actually pretty much the top health system in the country. We beat out a couple like Google and Apple and a couple things, which is pretty cool. So that's pretty neat. And then many other accolades coming in as well. The last thing, we just talked about amazing recruitment here with Dr. Kobashi. Well, we have some amazing recruitment to talk about with our Department of Neurology, the Stanley Appel Department of Neurology, which Stanley Appel is the outgoing chair for. Dr. Appel, as you know, let us know a while back that he was ready to transition. He is actually already heading up the Ann and Johnny Johnson Center for Cellular Therapy, which really cuts across all of our specialty areas and will really result in some amazing research. Now we get him full-time doing that as was planned. Dr. June Lee is joining us. Dr. Lee is at Wayne State University, whereas he is a sitting chair of neurology. So our three finalists were sitting chairs of neurology somewhere, which says a whole lot about the caliber of recruitment when they're already a chair somewhere else. And they said, I'm going to move up to the major leagues at Houston Methodist. And so we're really excited. He also was their scientific director for translational neuroscience. He actually specializes in myelin and some peripheral nerve issues and other things. He'll fit in really great here. He's going to be an amazing leader. He spent 9 years of his junior career there, 9 years at Vanderbilt, then went back there as chair. He's been an NIH-funded researcher since, I think, 2004, and very accomplished. So we're thrilled he joins us on June 1st. So with that, I'm going to wrap things up, and I think we've covered all your COVID questions. So I'm going to just wrap the entire day up here. I want to thank my distinguished colleagues here for being here and giving us such a great talk, and the work you do is really tremendous. So thank you to each of you. I want to thank Ben Moreland, Wendy Moreland, for your tremendous support. Thank you for your introduction at the beginning and with the task force. If you're interested in the task force, email us. Let us know. We'd love to get you engaged. So next month, we're going to continue focusing on the array of superheroes here at Houston Methodist. We're going to focus on the Linda and David Underwood Center for Digestive Disorders. So you're going to hear about gut health and very complex and a myriad of issues associated with that as well. So until then, seize the moment. Be ready to pivot safely if you need to, but let's hope between now and then we don't need to. And we'll see you on April 28th for that session. Thank you and God bless.